Hi, everyone, and welcome to the next session for our Advanced Practice Provider series for the UNC Lineberger Cancer Network. Today is Wednesday, October 20th, 2021. Thank you for joining. If you are having technical difficulties, please don't hesitate to reach out. You can call the phone number on the screen, 919-445-1000. You can also email unclcn@unc.edu. Next. Throughout our lecture, we will have some poll everywhere questions. You will also be able to ask questions at the end through poll everywhere. There are 3 ways to connect with us. You can join by the web by going to pollev.com and entering UNCCN. You can also join by text, texting UNCCN to 22333, as well as via an app on your Android or iPhone. Open the app and you can enter UNCCN for the username and click join. Next. To claim your continuing education credit, participants must attend for the entire lecture, at least 50 minutes of the lecture. And you have to participate and listen to the Zoom with the slides and video components. So just joining on your phone via audio, I'm sorry, but we are not able to qualify that for continuing ed credit. You can also join by watching the media site, but again, continuing ed credits, not allotted for that. So at the end of the session, you fill out the evaluation and select your certificate and claim credits within 7 days. Next. Please check out our other lecture series. There's some great topics happening in the patient-centered care lecture on the second Wednesday of the month from 12 to 1. Our Advanced Practice Provider series is on the third Wednesday of every month from 4 to 5. And then our Research to Practice series is on the fourth Wednesday at 12 noon. The lectures are recorded and available to view even after the live sessions through self-paced online courses. So check them out on the UNCLCN website. Next. So I'm very excited to have our speaker today, Dr. Tessa Andermann, join us to talk about common infectious disease, conundrums, and cancer. A great topic. Next. So Dr. Tessa Andermann is a relatively new addition to our UNC Chapel Hill. She started 2 years ago as an assistant professor in the Division of Infectious Disease. She came here to join the immunocompromised host infectious disease service. She is one of 5 attendings in the immunocompromised host service, with a particular focus on patients with hematologic malignancies and those who have undergone hematopoietic stem cell transplantation. When she is not in the hospital and clinic, she spends her time investigating the organisms that make up our gut microbiome and the antimicrobial resistance genes they harbor. She is particularly interested in how those organisms in the gut can cause both infections with antibiotic-resistant organisms, as well as how they interact with the immune system to impact cancer outcomes and alter the toxicity of cancer therapies. And I'm excited to hear about some of this in your lecture today. So Dr. Andermann, outside of your professional biography, anything unique you'd like to share with our audience?
Sure. So, and pertinent to this discussion, I am obsessed with British detective shows. And you'll see why that matters. But I secretly wish that I could be a detective, and I somewhat play one in my working life anyway.
Oh, that sounds great. I mean, I guess in this area, you must be at times. Great. Next slide. So we will test our poll everywhere. If you go to your website or applications, our test question is, cancer treatment is never affected by other diseases or conditions. True or false? So you'll have a second to go into your app and answer that question. Next slide. So our disclosures today, this activity has been planned and implemented under the sole supervision of course directors in association with the UNC Office of Continuing Professional Development. Dr. William Wood and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Tessa Andermann has no financial relationships with commercial interests as defined by the ACCME. Next. So great. Seems poll everywhere is working. Thank you for participating. Now I will turn it over to Dr. Andermann.
Thank you so much, Tammy, and thank you everyone for joining me here today. So today the topic is common infectious disease conundrums in cancer, and this will be a really practical session on what to do and tips on how to manage patients with cancer who have infections. So my hope is that by the end of this talk, you will understand the workup and management of febrileneutropenia and the workup and management of pulmonary nodules. And I'll start off with this first case. So Miss J M is a 68-year-old woman with follicular lymphoma presenting with fevers to 38.6 degrees Celsius 2 weeks after our CHOP. On review systems, she notes rhinorrhea, a scratchy throat, an occasional non-productive cough, and watery diarrhea. She denies any headaches, shortness of breath, abdominal pain, does not have any dysuria or rashes. On examination, her vital signs are normal apart from a fever. On exam, she has mild erythema in the posterior oropharynx. Her lung sounds are clear, abdomen is soft and non-tender, and she does not have any rashes. Her labs are notable for a low white blood cell count of 1,300 with an ANC of 900, low hemoglobin at 9.1, platelets of 115,000, and a creatinine normal at 0.8. So here is the question. Which of the following should you not obtain on further workup? So please put in your responses now. And I'll give you a few minutes to do so. So interestingly, it's only showing B. So hopefully that'll change. And that we're not stuck in some technical difficulty here. Okay, so hopefully that worked, but essentially my answer to this question is that urine cultures are not indicated in the absence of symptoms, and I know that that goes against some of the standard practice for most of us actually, and I'm just going to talk briefly about why that is. So there have been a few papers out about this. One that I'm showing here, this was a retrospective review, 433 episodes of febrile neutropenia, FN, in 317 patients with hematologic malignancies over 4 years. So these are very high-risk patients. They had 48 patients that were found to be symptomatic. So they had dysuria, frequency pain, abdominal pain or flank pain, and only 19% of those that were symptomatic were found to have positive urine cultures. 2.5% of those who were asymptomatic had positive urine cultures. And then here's the most important part that I wanted to share with you. So 0.6% of those who were asymptomatic, in that case, did those urine cultures change antibiotic management. So remember, of course, we're giving for febrile neutropenia in the hospital, we are giving broad spectrum antibiotics. And in very few cases, in fact, 2 out of 433 episodes, did we find that urine cultures actually changed to antibiotic management. So this is one of the reasons that I argue that we don't need urine cultures for most of our patients, even during febrile neutropenia and even in the most vulnerable of our patients. And so let's take a look then what the guidelines say. So the Infectious Disease Society of America, or IDSA, posted the asymptomatic bacteriuria guidelines in clinical infectious diseases in 2019. And they state, and I quote, patients with low risk neutropenia, so those who have a very short duration of severe neutropenia, defined as an ANC below 100, for less than 7 days, who are clinically stable, have only a very small risk of infection, and there's no evidence to suggest that asymptomatic bacteriuria has a greater risk than for non-neutropenic populations. What do they say about the high-risk patients, for example, those with undergoing stem cell transplant? So in patients with high-risk neutropenia, interestingly, they say we make no recommendation for screening. And that's pretty much what most of the guidelines say, that in high-risk neutropenia, there's really no data to suggest either getting urine cultures or not, regardless of symptoms. In these guidelines, they suggest only the screening and treatment of asymptomatic bacteriuria in pregnant women or individuals prior to undergoing invasive urologic procedures. And it's really unclear what to do in the setting of urologic malignancies, stents, and chronic catheters. So for the UNC BMT febrile neutropenia guidelines, we've actually taken out standard urine cultures unless the patient is noting any symptoms. Okay, so Ms. JM's workup remains negative and you want to send her home from the infusion center on oral antibiotics. Which antibiotic regimen should you not send her out on? The choices are A, levofloxacin plus augmentin, B, ciprofloxacin alone, C, ciprofloxacin plus clindamycin, and D, ciprofloxacin plus augmentin. And you can start entering your answers now. Hopefully this works.
We've got quite a variety coming in.
This is great. It's good to see
Yeah.
where people are at.
So how'd they do, or are doing?
So yes, so most folks answered ciprofloxacin, and in fact, that is the correct answer. Why is that? So the IDSA and then the ASCO combined outpatient febrile neutropenia guidelines from 2018 for low-risk febrile neutropenia state that the options for oral antibiotics include levofloxacin with or without augmentin, or ciprofloxacin plus augmentin, or ciprofloxacin plus clinda if the patient is allergic to penicillin. So these are the antibiotics that patients can go home on in the setting of low-risk febrile neutropenia, and sometimes we forget the augmentin in addition to the ciprofloxacin, and what we're really trying to prevent or to treat are infections with streptococcal organisms. Levofloxacin, the augmentin is optional for levo because levo has some limited streptococcal coverage and other gram-positive coverage, whereas ciprofloxacin really doesn't have much of any of that. So hence the cipro plus augmentin or clinda. Okay, so per the IDSA febrile neutropenia guidelines of 2010, granted they really do need to update this, but these are still the guidelines that we use. So patients are considered low risk, they're therefore okay to send out on oral antibiotics if they have a limited duration of severe neutropenia, so again ANC below 100 for less than 7 days and they're clinically stable. And they also need to have a MASC risk score greater than or equal to 21. Now, I've never used the MASC risk score, but perhaps some of you have. So the MASC score is the Multinational Association for Supportive Care and Cancer Risk Index score. And just to make it as confusing as possible, a higher score means that you are lower risk. You'd think they'd want it the other way. But these include things like the patient is stable, they do not have hypotension, they don't have COPD, they have a solid malignancy, no dehydration is present, they are outpatients, and they are younger than 60 years. So again, higher risk equals lower, higher risk score equals lower risk, and therefore the patients can be sent home on oral antibiotics. Now, what about high-risk febrile neutropenia? These are the patients that I predominantly see. They have undergone blood and marrow transplantation, or BMT. They're anticipated to have severe neutropenia for a prolonged period of time, greater than 7 days. They often have severe comorbidities. COPD, heart disease, and renal dysfunction are the primary ones. They have high-grade mucositis, and then they have a low MASC score. There's also a CISNY score that's used as part of this. I didn't want to go into that. But for high-risk febrile neutropenia, What do we do? So a patient comes in with febrile neutropenia. The first thing in my mind is to, now you get to play detective, right? And this is what I do, and this is what I love doing. So you want an infectious workup that includes a detailed history and physical exam. That goes without saying, but what do I really mean by that? So I mean taking a very close look at the patient head to toe. And what I often find are oral lesions that haven't been discovered because people don't have enough time to really spend time looking in the mouth, which is understandable. But I find vesicular lesions or ulcerated lesions that end up being HSV, VZV, rarely CMV. And in some cases, I've seen histoplasma or tuberculosis. I look at the upper palate and I look for signs of necrosis, which to me indicates invasive fungal infections. And then I also assess dental pain and abscesses, which to me indicates potentially an infection with anaerobes, oral anaerobes. Often patients will forget to talk about the sinus congestion and the pain that they're having. If it's unilateral, we tend to think more bacterial. And in these very vulnerable patients, we have to consider Staph aureus, Pseudomonas, other gram-negative organisms, and rarely molds, which is why we get the CT sinus and the orbits, and we also call ENT if we see anything on imaging. In the setting of bilateral sinus congestion, I think more respiratory pathogen panel, so thinking more viruses, but you know, I often will do the workup for all of these depending on how patients present. And then, of course, if patients are endorsing diarrhea, equaling 3 or more watery stools in 24 hours. For watery stools, I think C. diff or norovirus. Norovirus is present on our GI pathogen panel. For bloody stools, which is less common, I think of sort of the classic foodborne illnesses like with Salmonella, Campylobacter E. coli, again on our GI pathogen panel. And then only in the very immunocompromised, and I mean not even necessarily the autologous stem cell transplants, although rarely this can happen, but more in the allogeneic stem cell transplants. Occasionally in the ALL patients, we'll see CMV causing generally watery diarrhea. And then the other key is to do a thorough skin exam. So this has been really important for me and has yielded quite a bit in understanding what may be causing febrile neutropenia in my patients. So if you find pustules, think candidemia or think strep or staph folliculitis. If you find purpuric or necrotic lesions, think ecthyma gangrenosum, which is basically just an eschar or necrotic lesion caused by molds or Pseudomonas, other gram-negative organisms, Staph aureus. I will find nodules, erythematous or not, purpuric or not, that can be caused not only by molds, but also think of endemic fungi like blastomycosis, coccidioidomycosis, which we don't see much of here. And then I've seen non-tuberculous mycobacteria and tuberculous mycobacteria causing nodules, as well as nocardia. And then, of course, for vesicles and ulcerations, HSV and VZV. And then, of course, I take a look at the lines and note the data placement and appearance. This is not the, these are not the only exam findings that I pay attention to, but these are sort of the highlights and some that I've found that I've been able to contribute to when the cause of febrile neutropenia is unknown. And so these aren't the exact pictures of the patients that I've seen, but these are representations of how I've been able to diagnose patients. So in A, this is a pustular lesion. In B and C, we have these necrotic lesions, ecthyma gangrenosum-like. And then in D, we have a vesicular lesion covering the body. And so in my patients who I found pustular lesions on their abdomen, I diagnosed them with candidemia. I've definitely diagnosed aspergillus, fusarium, and other molds from these purpuric lesions. And it's hard sometimes because patients with no platelets will have purpuric lesions. So I just watch them. And if they grow or they start to have an erythematous border like this, that's when I call in derm. Now, of course, a disseminated vesicular rash, we think of VZV, but I've actually diagnosed VZV encephalitis in a patient who was afebrile and had a rash on their inner thigh. So these are all clues that you can use as a detective to find potential causes for febrile neutropenia, and those have been helpful for me. And then, of course, consider non-infectious causes of febrile neutropenia. We all think malignancy and cytokine release syndromes or engraftment syndromes, But even in patients with significant thrombocytopenia, I've diagnosed DVTs and PEs. And there have been a lot of drug fevers, I'm sure that you've seen as well. We see this especially with beta-lactam antibiotics, but it really can be to any antibiotic. And if they have a white count, I tend to look for eosinophilia. I look at their LFTs, and those can be some clues. And sometimes these are the ones that can be missed sometimes, and they're pretty easy to work up. So aspiration, not even pneumonia, aspiration pneumonia, but just aspiration alone. Acalculous cholecystitis. Pancreatitis is often forgotten, especially in the ICU, and I send a lipase. Mesenteric ischemia is often forgotten, and I send a lactate. And then in our ICU patients who've been languishing on pressors, I think adrenal insufficiency and thyrotoxicosis. And so these are the things, I have a list of all of these, and I really kind of go through pretty systematically what might be causing it, and then go for the most common, and then in my next workup, if they're still febrile and we haven't found a cause, then I go for the lesser common causes. So I highly suggest having a very systematic approach to these patients. And we know that for patients with high-risk febrile neutropenia, we start them on empiric therapy, and this can include cefepime, ceftazidime, piptazo, and meropenem. The IDSA guidelines do not make any distinctions between antibiotics, with the exception that ceftazidime is noted to have minimal strep coverage, and we've definitely seen strepmitis breakthrough bacteremias in those patients. But apart from that, these are all anti-pseudomonal beta-lactams, and they're all up for grabs when patients develop febrile neutropenia. But I would actually like to argue that our antibiotic choices matter. Of course, this is my research. I think about the gut microbiome quite a bit. And, you know, doing a lot of my research, I've become increasingly convinced that our antibiotic choices impact not only infection risk, but also our response to chemotherapy, the toxicity to chemotherapy. This was very nicely demonstrated in these 5 studies that came out in 2017 and 2018. This is a lot of information, but basically these are all studies with solid organ malignancies in which patients received anti-PD-1, anti-PD-L1, or anti-CTLA-4 immune checkpoint inhibitor therapy. And they looked at the gut microbiota of these patients and looked at those who responded versus those who did not respond. And the organisms that I'm highlighting in blue are not only the ones that were found in the responder patients to a greater degree than in the non-responders, they're also all anaerobic organisms, obligate anaerobes in the gut that don't live in oxygen. And these are easily killed off by the antibiotics that we give, especially the antibiotics that have anti-anaerobic activity. And so our antibiotic choices really do matter and can really impact infection risk and outcomes for patients. This is, of course, still in its infancy in the research world, but for that reason, I really want to argue to think about the anaerobes and to save the anaerobes. And when you're making these choices, think about the antibiotics that have less anaerobic activity that I'm showing here in red, cefepime and ceftazidime, and only consider piptazo or meropenem in the setting where these have more anaerobic activity when patients have something along the lines of typhlitis, an abdominal abscess, cholecystitis, and things like that, in which you really do want to think about covering anaerobes. Okay, so moving on. So that's my tiny little soapbox. So what about empiric IV vancomycin? So IV vancomycin is often started right away with the anti-pseudomonal beta-lactams, but technically, according to, again, the IDSA 2010 guidelines, it is to be used only in the following 6 scenarios: when patients are hemodynamically unstable, when they have pneumonia, when there is an actual clinically apparent catheter infection with purulence and erythema around the catheter, when they have known colonization with very resistant strep or staph, when they have skin and soft tissue infections, or if they have severe mucositis, only if ceftazidime is used, because again, that's where we see these streps coming about. And in this case, these streps will be covered by vancomycin. In the case that patients are started on vancomycin, the guidelines and your friendly infectious disease physicians, friendly neighborhood infectious disease physicians recommend stopping vanco if there's no evidence for MRSA or an organism that requires vanc after 2 to 3 days of negative cultures. And what to do when patients remain febrile on antibiotics. Now this I often see is not followed, but I really do strongly recommend that for patients who have had febrile neutropenia for less than 4 to 7 days and they're hemodynamically stable, that you continue the current therapy. There's no reason to escalate to, for example, meropenem and vanc at that point. If this is a situation of febrile neutropenia longer than 4 to 7 days and they remain hemodynamically stable, that's when I start to look at for other causes of febrile neutropenia. I repeat the standard culture workup. I get a CT chest plus or minus a CT sinus if patients have any symptoms, and then I importantly add mold coverage or broader antifungal coverage than often the fluconazole that they're on. So this often means an azole like posaconazole. It can also mean mycofungin or another echinocandin, but we add mold coverage to cover for pulmonary fungal infections. Now, if they're hemodynamically unstable, you're not thinking pulmonary fungal infections because those don't cause patients to crash. You're thinking now covering for some of these more resistant organisms. So you can broaden your coverage at that point and include coverage for MRSA, Candida, multi-drug resistant organisms. And I would also suggest in those patients crashing in the ICU, considering a single dose of tobramycin IV, especially when the cause of febrile neutropenia and crashing could be in the abdomen. So a single dose of tobramycin IV will not generally harm patients' kidney function. And then the next day you can reassess to see how they're doing. You have more data back to either cover for infections in the gut or pneumonia. And so from there you can decide, you know, what your more ideal antibiotics will be. But that's often a go-to for me. And then the question of when to stop or narrow antibiotics. So this is another thing that I feel fairly strongly about. Standard protocol means stopping antibiotics when patients are afebrile and they are no longer severely neutropenic. Their ANC is above 500. Or if they have a bacteremia or pneumonia, continuing the antibiotics to cover for that particular indication. There is now a push for early de-escalation, and at UNC and at other places, in the BMT division, for patients who are afebrile for 5 days, still neutropenic, if they don't have a documented infection, consider de-escalation and restarting prophylaxis. And we've had really good outcomes with these patients. I've not studied them systematically, but just anecdotally. Now, there have been many studies demonstrating that early de-escalation is actually safe and decreases the time on IV broad-spectrum antibiotics, which is good, again, thinking about the gut microbiome. So in this case, they actually took very high-risk adults, and they de-escalated after 72 hours, so even sooner than the 5 days that we do here. And they found no difference between these two groups that were randomized. They found no difference in median neutropenia duration. They found no difference in recurrent fever or infections. And then most importantly, no difference in adverse events and serious adverse events. So that's key. I should say for actually serious adverse events, those were, let me restate that. For serious adverse events, those were more likely to occur in the control group who had been on longer antibiotics. So that's actually important and something to note. Well, what about when you actually find an infection? Of course, I can't cover all of the many topics that we teach our ID fellows, but I just wanted to bring up two that I encounter very commonly. So bloodstream infection management tip number 1. The most common question we get is when to take the line out. And so if you consult the IDSA catheter-related infection guidelines from 2009, again, these are pretty ancient. Hopefully they'll be updating these soon, but they still apply. And, you know, we have patients with long-term catheters. So they state that long-term catheters should be removed from patients with catheter-related bloodstream infections associated with any of the following conditions. In the setting of severe sepsis, suppurative thrombophlebitis, basically an infected clot, endocarditis, continued bacteremia despite 72 hours of adequate antimicrobial therapy, or infections due to Staph aureus, Pseudomonas, fungi, and mycobacteria. Why those organisms in particular? Well, these are basically sticky bad bugs. They form biofilms on the plastic of the catheter, and regardless of how long you treat, you're never going to be able to really get rid of these infections until you remove the source of infection. And so for any of these sticky bad bugs, take the line out. And for any patients who are severely ill, also take the line out. The bloodstream infection management tip number 2 that I wanted to share with you is to really consider consulting ID for any bloodstream infections, but especially Staph aureus, Candida molds, Pseudomonas aeruginosa, and multi-drug resistant organisms. And most subspecialties don't have to justify their own existence through randomized controlled trials, but ID, we've justified our existence by demonstrating that ID consults in the setting of Staph aureus, bacteremia, and candidemia actually reduce mortality and improve outcomes. And so, we have the time to be able to look for sites of metastatic infection. For example, with Staph aureus, patients can have septic joints that they don't complain about. And then when we examine them, we find that these are a source for ongoing infection, and we really can kind of push the surgeons to take care of infected joints, to push for TEEs, and to really kind of make sure that we've got adequate source control. So please consult us. Okay, so next major topic, C. diff management tips based on the new IDSA 2021 updates. And this was very interesting for us because if you remember standard C. diff management, in the first occurrence, we are supposed to start PO vancomycin, and that's really what we've been doing for several years now. It used to be Flagyl, now we're actually using PO vancomycin. However, these updated guidelines were quite a shock. So for first C. diff occurrences, we are actually encouraged to start fidaxomicin more than PO vancomycin, and that's because fidaxomicin has a much narrower spectrum and can really disrupt the gut microbiome quite a bit less, and therefore actually reduces recurrences, which has been found in the randomized trials. Now for C. diff recurrences, we've been using fidaxomicin to some extent, but they really say that the data is very good for the use of fidaxomicin over a PO vancomycin taper, which was previously recommended. For multiple recurrences, again, fidaxomicin. Alternatives include, beyond this vancomycin taper, to use PO Vanc plus rifaximin, and you can check out the guidelines for the recommendations on duration, or a fecal microbiota transplant. We do have on the adult side Sarah McGill, who performs FMTs on immunocompromised patients who have recurrent C. diff, so that's still an option. It's becoming, unfortunately, less and less of an option as companies that supply the precious stool for FMTs are no longer providing that under pressure from the FDA, given some recent infections resulting from FMTs. So it's still an option. Please contact anyone from Immunocompromised ID to get that set up. But it is less and less of an option these days. And so we are using fidaxomicin to prevent recurrences. We're using long tapers if fidaxomicin is not available. And I didn't include it here, but bezlotoxumab is a monoclonal antibody that we're also using to prevent recurrences, just not very commonly yet, generally because of cost. At UNC, the use of fidaxomicin is somewhat restricted, but these are the guidelines now. To use it for recurrent disease, so not necessarily for first line, the reason being that the insurance companies have not been paying for fidaxomicin. That may change soon. But at UNC, we use it for recurrent disease or for any two of the following: older age, severe C. diff, immunocompromised state, or if they're receiving antibiotics for another infection unrelated to C. diff. Or if you consult ID, GI, or the antimicrobial stewardship group. Under consult, you can also start fidaxomicin. So it's something to consider, and it's in line with current IDSA guidelines, and the insurance companies now just need to catch up. Okay, so summary of teaching points from case number 1. Urine cultures should be performed only if symptomatic. Oral antimicrobial management of low-risk patients with febrile neutropenia is possible using Cipro plus Augmentin, not Cipro alone. Clues to look for in assessment of patients with febrile neutropenia include a thorough skin exam, an oral exam, and others considering more subtle signs indicating the source of infection. Not all IV antibiotics are created equal. Consider avoiding anaerobically active antibiotics, given preliminary research studies on the role of the gut anaerobes in improving cancer outcomes. Consider early de-escalation of antibiotics if the patient remains afebrile without an infection for 5 days. instead of course, waiting until the ANC goes above 500. Take out the line with severe bloodstream infections and infections with specific sticky organisms that we talked about, and then consider that vancomycin is now first-line treatment for initial C. diff infection. Okay, so let's take a breather. Now I will move on to my next topic. This is case number 2. So case number 2 is a 34-year-old man with AML who underwent an allogeneic hematopoietic stem cell transplant. He became febrile to 39 degrees Celsius starting on day +7 post-transplant with an ANC of 0. He was started on cefepime and pan-cultured, but his studies remained negative. After 4 days of fevers, the patient remains hemodynamically stable. So the question is, A, should you switch cefepime to meropenem? Should you, B, obtain a CT chest? Should you switch fluke to mica, switch fluke to posa, or continue to watch on cefepime? And please enter your answers now. And go.
Here we have some answers coming
Good.
through.
Great.
Looks like majority are picking E.
So in some ways that is correct. Continue to watch on cefepime. However, you want to continue to work this patient up after 4 days. You want to obtain a CT chest, reevaluate for sources of infection, and based on the results of your CT chest, start mold prophylaxis as well. So I'm going to say B is the correct answer because we always want to remember to look for these occult sources of fevers in our very immunocompromised patients. So let's say that we have a hypothetical patient with a CT chest shown on the right. So this is our BMT patient, underwent an allo, and he's got fevers, and now we see these round nodules bilaterally in the lungs. And maybe some of them have a little bit of this halo sign, maybe here, where you see a little bit of fuzziness around the nodules. So what's your differential diagnosis here? Well, the first thing that we think about, of course, in these patients are fungal organisms. We think about aspergillus, less we think about mucorales, but those are possible. And I don't want to forget, of course, endemic fungi like cryptococcus really can look like this, histo, blasto, and coccidioides also. Don't forget about bacterial causes of these nodular lesions in the lungs. So nocardia, which is an organism of bacteria in the soil. Patients will give you a gardening history, for example. They may have tuberculosis or other non-tuberculous mycobacteria to think about. And then actinomyces is one that we think about when patients have any dental issues or history of dental procedures recently. Less likely, we think about viral or parasitic. We really don't see a lot of viral or parasitic causes of nodular lesions, although, never say never. And then not to forget the non-infectious causes always. So drug reactions and malignancies can absolutely look like this. We see COP, cryptogenic organizing pneumonia, that looks like these nodular lesions, and that is defined by these same nodular lesions actually moving all over the lungs. So you'll see nodular lesions in one region on one CT, and a few weeks later, nodular lesions in another region. And I've caught COP, or BOOP is the other term for this. I've caught that many times, and they come in with fevers and they're coughing and it looks like fungal nodules, and you start them on posaconazole or ambisome, and it turns out that this is really a drug reaction or an idiopathic reaction. So that's something to also keep in mind. So I'm going to present to you the Andermann workup for nodular pulmonary lesions. Other doctors, other ID doctors may have other workups, and it's going to be quite extensive. I don't do everything all at once, but I consider the most common things and then move from there based on the results. So I ask them a lot of questions, and this is really part of your extensive history and physical exam. I ask them about TB risk factors. Many patients will have had time in prison. They've been homeless. They've traveled to endemic areas. They've had uncles or aunts die of TB in the past. So I always elicit those history points to give me a sense of their risk for TB. We don't see a lot of TB, but it's pretty devastating if it's missed. And we've all missed it, unfortunately, including myself. So I assess their animal exposure risk. So if they have a pet bird, I think of crypto. Even if they don't have a pet bird, but they sit outside feeding the birds, I've had patients with cryptococcus. I've had literally patients say that they've gone into caves and they come out and it turns out to be histoplasmosis. Less common, but something that we see on the infectious disease boards. If they own horses, we think of Rhodococcus equi, again, nodular lesions. Often our patients here in North Carolina have a lot of gardening exposure. So I think about nocardia or construction exposure, and I think about other molds. Assess travel risk, cocci on the West Coast, paracocci in Latin America, penicillium in Southeast Asia, and then recent dental procedures, thinking about actinomyces. My workup doesn't include all of these all at once. However, I do think about, if there's concern for histo, crypto, other fungi, I think about getting these as first line workup. And Fungitel can give you a sense for kind of general molds with some exceptions. Galactomannan is more specific to Aspergillus and not to Mucorales. And then of course a quantiferin if I'm concerned about TB, although in immunocompromised patients we often get indeterminate quantiferins, which essentially means that their T cells are not going to give us a result. It's not that they are almost positive, it's just that the test isn't working. So often our quantiferins are not helpful, but I think about it. And then I often recommend a BAL with biopsy when these lesions are above 1.5 centimeters in the lungs. The larger, the more likely you're able to actually get culture results from a BAL. I try to get the BAL as soon as possible before starting a nasal, but if they have a very large lesion, if they are unstable, if they have really any respiratory symptoms, I just start them on the antifungals and ask pulmonary for a BAL. In this case, I get all of the stains and cultures. I ask for galactomannan. Sometimes that's forgotten. I ask for an actinomyces screen if they have any oral lesions or dental history. And I'm less likely in these cases to request pneumocystis, CMV, or other viruses, although, again, never say never, but these are less likely in the setting of pulmonary nodules. So I know that this is a lot, but this is just to sort of introduce kind of, the extensive workup and the extensive history that I really like to take for my patients, which can give you a clue. Now, this is in contrast to the differential diagnosis for diffuse ground glass on a CT scan. So in this case, you can see kind of this patchy haziness in both lungs, and this is throughout the lungs. There are always situations where patients aren't just, single nodules or just diffuse haziness. They might have something in between. And so, it's never really simple to kind of figure out what your differential is. But if you see this really diffuse haziness, ground glass without any nodularity, I think less likely of the molds in that case, and I think more likely of the respiratory viruses, as well as some of the herpes viruses. So we've seen this in patients with HSV, VZV, CMV, and very rarely HHV6, for example. I think of pneumocystis, number one. That's a major cause for our patients. Toxoplasma is often forgotten, but that's another one that can cause this diffuse haziness. Atypical bacteria, meaning not the standard strep, staph, pseudomonas, but more along the lines of chlamydia, sometimes Legionella, and mycoplasma, and the other organisms that don't respond to the beta-lactams, but actually respond to azithromycin or doxycycline, for example. And then drug toxicity is a major cause of this patchiness, and as is volume overload. So that's how I distinguish my workup when I take a look at these CT scans and I go down to radiology and I ask them. And some radiologists are really helpful in kind of giving a sense of what they think is most likely as well. Okay, however, the use of the CT scan to identify an organism is very challenging, and I'm showing you here a bunch of different scans with a bunch of different organisms, and I want you to find the fungus. So take a little moment, this isn't a poll, but just take a moment to look through these and to think, what would I, consider starting empiric therapy for with an azole? What of these looks to me like a classic mold? So maybe A, B, I would think. C to me looks, you know, with these air bronchograms more like a bacterial pneumonia, classic bacterial, so does D. G looks pretty classic for a mold, maybe I. So kind of hard to say, right? They all could be, but it's hard to say. Well, the ones that I'm highlighting here with a red asterisk are molds. And you can see that your CT scan is not perfect. So, you know, in this first one, I thought, yeah, it could look like a mold. Maybe there's some halo sign around that Pseudomonas in that case. You know, nocardia in this one. Lymphoma also can present with nodularity. Rarely, I've actually never seen this myself, but theoretically CMV, but I think that that's much lower on the list. And then Cryptococcus looks just like Aspergillus, which is why we always get a cryptococcal antigen. So it is very hard to tell, so definitely keep your differential broad. Okay, so the patient undergoes a BAL and his galactomannan is positive. The fungal cultures grow Aspergillus, which is what you'd expect with a positive galactomannan. So what antifungal would you start? Would you start Vori? Would you start Posa, isavuconazole, micafungin, or ambisome? And I'll give you a moment to enter in your answers.
And while everyone is working on this answer, I just want to remind everyone to get your poll everywhere questions for Dr. Andermann at the end of the lecture. So write them down and you'll be able to enter them at the end. So how are they doing?
So this is great. So actually, this is a little bit of a tricky question because you can use any of these to treat Aspergillus. So really, the question is more of a, what is the first line recommendation? In reality, I will start any of these for Aspergillus. Voriconazole, however, is the correct answer, and I'll show you why that is. So this is still first line for Aspergillus infection. Even in the transplantation 2021 guidelines for Aspergillus, voriconazole is recommended first line. However, we have some new additions for treatment that can be alternatives. We know about isavuconazole. There was a randomized controlled trial demonstrating that isavuconazole was non-inferior to voriconazole for first-line therapy of Aspergillus infection. However, anecdotally and increasingly in the literature, we're finding more breakthrough infections on isavuconazole. It still needs to be determined whether that is actually the case, but even in my own practice, I've seen a lot of breakthrough Aspergillus infections with Aspergillus that is actually azole sensitive. And so I've been using isavuconazole less and less, but the new addition to the family of possible azoles to use is posaconazole. Posaconazole is FDA approved only for actually prophylaxis in graft versus host disease and in AML induction. And it's not been technically used for first-line Aspergillus treatment until this year. Now we finally have our randomized controlled trial demonstrating equal efficacy, or at least non-inferiority for posaconazole compared to voriconazole, and in fact, much lower risk of side effects with posaconazole compared to vori, and we know that as well. ISA also has fewer side effects. And so now a lot of us have been using posaconazole first line, given that voriconazole does have those side effects. Mostly we see patients with not really altered mentation, but actually hallucinations, visual hallucinations, and we see a lot of transaminitis in those patients. So posaconazole has been increasingly our first line therapy. Ambisome is also still our alternative therapy and can be started for very large lesions. We cannot use ambisome first line in CNS infections. That's something to note. However, if patients fail an azole, they should be started on ambisome as your salvage therapy, and resistance testing should be sent on cultures. We treat Aspergillus generally until radiographic resolution, or at least 12 weeks, whichever is later. And often we do find that radiographic resolution takes some time. So we will get kind of repeated CTs for that, and may start earlier if we really think that we're just seeing kind of a residual scar. So that's kind of the current management strategy for Aspergillus. Okay, so our case, so this is our BMT patient. You start him on voriconazole, and 2 weeks later his ANC is higher, great, but his chest CT looks worse. The lesions are bigger. So, and he reports that he's compliant with his medication. So what's going on? What do you think the lesions, why do you think the lesions are becoming bigger? You can see here on the CT scan that, you know, there are more of them, they are larger. So what could be causing this? Well, the first thing that, of course, all of us think of is failure. Our drug failed. We need to put them on a different azole. And it could be because mucorales, for example, are resistant to VORI. So this could be a mucorales infection. We could have an azole-resistant mold, like an azole-resistant aspergillus, which has been fairly low incidence in the United States, but is increasing. So I'm starting to definitely see more azole-resistant aspergillus. This is more common in Europe at this point. We'd have to think about the dose. So we get a VORI trough and make sure that the trough is adequate, above 2. And then think of, you know, you can be on the right drug with the right bug, and yet the host is unable to mount an immune response. And I've definitely seen that. In patients with an ANC of 0, there's nothing often that you can do to kind of clean up this infection, because you actually need an immune system in addition to the antifungals to treat any infection. But something that I also want you to consider here is that this is not failure. And interestingly, this could be a sign of neutrophil engraftment. Even when the ANC is below 500, we see neutrophils rushing to the site of infection, and then the lesions actually look larger because they're starting to cause inflammation finally. So I don't want, you know, folks to get too alarmed by small increases in size for these lesions. Obviously, new lesions are concerning and do suggest failure. Okay, what treatment would be least effective for breakthrough infection on voriconazole? And this should have been a poll everywhere. But I will let everyone think about it. So what would be least effective? So this patient broke through voriconazole. What can we use now? Should we use POSA plus ambisome? So I should say this is least effective. So which one is going to fail more likely? So should we use ambisome, posaconazole, isovuconazole plus ambisome, ambisome plus micafungin? So what's least effective for breakthrough infection? And I'll let you think about it and decide which one you'd pick. So in this case, unfortunately, we don't have a poll everywhere, but in this case, we would not want to go to another azole. Remember, the guidelines really suggest that we consider ambisome. Have I gone to another azole? Yes, in the past when we, you know, have a patient with a kidney transplant and we're worried about using ambisome. Posaconazole is a broader spectrum antifungal. It covers mucorales. It covers some of the dematiaceous molds that voriconazole doesn't. And so you can have some increased efficacy, but really the answer is you need to have ambisome in your regimen. So all of the other regimens with ambisome are really the right answer for breakthrough infections on VORI. And what about this CT? So let's say in this, you know, other hypothetical scenario that we have a patient who actually has this CT. So what you see here is this kind of rim enhancement here. You see a halo around the outside, and you see this, this kind of fuzziness in the center. So what is this called? So this is actually called a reverse halo sign, and it is caused by rapid expansion, angioinvasion, and the resulting loss of blood supply in the central area of necrosis. So this is actually a danger sign, and often indicative of mucorales, and can be seen with other molds, but is associated with the really rapid growing molds, the lid lifters that in the Petri dish, they grow so fast, they lift the lid up. Those are organisms like Rhizopus and Mucor and things like that. They grow so fast, they outgrow their blood supply, and they have necrosis in the center. That is where you really want to use your ambisome, where we really get concerned about mucorales infections. Now, no standard guidelines exist for the treatment of mucorales, but something that is often forgotten is that surgical resection is key. And unfortunately, these are the most vulnerable patients that often the surgeons have absolutely no desire to touch. But these are the patients that really benefit from, especially if there's one lesion, surgical resection of that lesion, because we know that they will never resolve their infection with antifungals alone. We use ambisome first line. Often we use a combination, although there's little data to support that. And something that's key for everyone to remember is that delaying ambisome by more than 6 days increases mortality twofold. So in that case, you don't want to take the time to wait for a BAL to start ambisome. You want to actually start your antifungals first. I often start ambisome plus posaconazole, and then go for the BAL and then talk to the surgeons. And of course, ID is really helpful in this setting because we can really kind of make sure that the surgeons understand our concerns and make sure that they're on the right antifungals in that setting. So, okay, so what have we talked about for case number 2? CT chest is important for febrile neutropenia that is longer than 4 days. If hemodynamically stable, there's no reason to broaden antibiotic coverage, no reason to start meropenem instead of cefepime, for example. Consider a broad differential in your assessment and management of pulmonary nodules and ask a lot of questions about risk factors. Remember that first-line therapy for pulmonary aspergillosis remains VORI, but isavuconazole and posaconazole are now options as well. Treatment of an invasive pulmonary and fungal infection that fails azole is ambisome, and start your ambisome right away. And then consider surgical management of mucorales infections, especially when you see something like the reverse halo. Okay, so that's the end of my talk. A little infectious disease humor here. So now I'd love for any questions. I think we have 4 minutes, and I'd love to answer any questions that you have.
Thank you, Dr. Andermann. What an informative talk. So thank you for sharing your wisdom with us. So to our audience, we have just a quick minute or two that you can send some questions through your poll everywhere. So while we're waiting for those to come through, I feel like I see ground glass opacities on like everyone's chest X-ray, chest CT, especially lately.
Yeah, and that's when walking over to the radiologists in the basement can be helpful, because there's ground glass nodules, and then there's ground glass opacities, and there's diffuse ground glass, and all those things mean many different potential etiologies for infection. So we're still waiting for questions to come in, but I highly encourage any questions. Hopefully this wasn't too easy of a talk. Hopefully this was a little bit informative for you. And I'd love to have any practical questions on management that that's come up for you.
I will, Tim will let us know if some questions come through. If you want to advance the slides, I'll start wrapping up for us as we're hitting the 5 o'clock, and I'm sure people are ready to get home for dinner. So thank you all for joining us. Thank you, Dr. Andermann, for your time and sharing your knowledge. Thank you to our whole telehealth team that makes this all possible. Next. As a reminder, some upcoming lectures are our Research to Practice. Dr. Foster will be talking about leukemia management. Our next Advanced Practice Provider lecture, Dr. Winzelberg, will be sharing his wisdom on promoting effective communication and advanced care planning. And then our patient-centered care lecture, Mary Dunn, one of our very own APPs, will be talking about testicular cancer. Next. And don't forget about our self-paced courses. Check them out on the telehealth website, learn.unclcn.org. The latest lectures are here. Go check them out. You can still obtain continuing education credits. Next. And thank you again for participating. Don't forget to fill out your continuing ed and claim your credits, and reach out to us for questions and check out our monthly newsletter. Thank you all.
Thank you all.
Thank you, Dr. Andermann.
Thank you, Dr. Andermann. We did not have any other questions come in, and if you do want to see where that recording will be, I'll go ahead and post that. I posted something else by mistake, but we'll go ahead and post the link to the recordings, and the recording of this event will be available on Friday. So thank you so much.
Also, if anyone has any questions, please feel free to reach out with an email. You can easily find me, Tessa Andermann, at UNC. So I'd be happy to answer any questions.
Great. Dr. Andermann, that's very generous. Thank you so much.
Thank you, everyone. Have a great
Thank you,
night.
everyone. Take care.